السلام عليكم ورحمة الله وبركاته. اسمي محمد حسن عبد الله ضحى الله. I will be talking about hematological and neurological sequela of COVID-19. So first, let's address the elephant in the room. There's been much talk about convalescent plasma, both in the press and في السوشيال ميديا. ناس كتار بيتكلموا عن convalescent plasma وإنه it's a therapeutic option for COVID-19. So let's address this issue. It is an old treatment technology. It dates back about 100 years. There is some evidence for benefit against other pathogens, and there were some case series in the MERS and SARS outbreak that documented that it's safe and it led to faster viral clearance after the administration of the convalescent plasma, especially if you give it early on in the disease course. يعني إذا دخلت أديته متأخر, you might not get as much benefit. لكن the sooner you get the convalescent plasma to the patient, the better outcome that they might have. في studies صغيرة عملوا small trial في الصين where convalescent plasma was administered between day 10 and day 22 after admission to patients who are on mechanical ventilation who received antiviral agents and methylprednisolone. And this might be a confounder here. إنه هن أخذوا antiviral agents وأخذوا prednisolone or methylprednisolone. So this might affect the study outcomes. وبرضه ما كان عندهم control arm عشان يشوفوا إنه effectiveness شنو. They did say that they could not assess the effectiveness, but they mentioned that there was no adverse effects that were noted. So at least this is sort of a safety study almost for convalescent plasma in COVID-19 patients. There are potential risks that we know about previously, such as transfusion-associated circulatory overload. والعيانين اللي راقدين ال ICU, they already suffer from issues of circulatory overload. So you might want to be careful when you administer the convalescent plasma. If it means that إنه هتبقيهم more overloaded, then you might want to delay giving the convalescent plasma maybe a day or so. Maybe give them some diuresis if possible, to get rid of some fluid if possible, or perhaps if they can get if they are getting fluids, you might want to reduce the other fluids that you're giving. And another issue is transfusion-related acute lung injury, and this is injury from the some antibodies from the transfusee itself to the lungs. وأصلاً عيانين دول عندهم damaged lungs, so you worry that it might cause more damage. If you suspect there's a trolley, you immediately stop the transfusion and you treat it. So I'm not going to go into details about trolley here. There are some other several trials ongoing for convalescent plasma, so stay tuned to these trials in the near future, inshallah. Convalescent plasma does create a therapeutic loop. فالعيان اللي اديته أو كان عنده convalescent plasma ويعمل donation للبلازما بتاعته, والبلازما عملية test, and then it's transported and stored and concentrated. They give it then to the patients in the hospital. Once the patient becomes better, then they can also become a donor. So you create a therapeutic loop in a sense. So what is needed to use this convalescent plasma? So this is FDA recommendations for the investigational COVID-19 convalescent plasma. So this is where I got this information from. Regarding the patient that is receiving the convalescent plasma, they need to have laboratory confirmed COVID-19. فلازم تعمل لهم PCR, ما بس إنه like presumed patient under investigation for COVID-19. No, they have to have confirmed disease before you give them the convalescent plasma. Severe or immediately life-threatening COVID-19, لأنه this is still in trial phase. This convalescent plasma for COVID-19 is still in trial phase. عشان كده we give them to those who really need it, those who cannot wait for trials to end before giving it to them. And you also need a consent, obviously, and it has to be an informed written consent from the patient or their next of kin in order to preserve their dignity and respect their wishes also. So you don't just give it to anybody. You need to get informed written consent. Regarding the donor, they have to have some evidence of COVID-19 in the past. Either when they were ill, they had diagnostic testing, nasopharyngeal swabs, or once they become better, once they recovered, they got tested for antibodies. And this is also still being developed. It is being developed quickly, but it's still in development phase, this antibody testing. But once it's more widespread, it can, it opens up the door for many donors to come forward, especially those who did not undergo diagnostic testing when they were actually sick. And a lot of patients are like that. So once antibody testing is more widespread, it opens up door to more donors for convalescent plasma. The other requirement is that they need to have been completely resolute. They have to have complete resolution from all symptoms for at least 14 days before donating the convalescent plasma. Some say even 28 days, but 14 days is the minimum that was noted in the FDA recommendations. They don't need to have negative viral test, but they need to be clear of all symptoms in order to be donors. Because you don't want to administer HLA antibody with the convalescent plasma, you either get the donation from a male or from a female who has not been pregnant in the past or before, or a female who had a negative HLA antibody test since the most recent pregnancy. And this includes pregnancy that ended in live births, that ended in abortion, or non-live birth. So you have to have this a negative HLA antibody test for those who had previous pregnancy. And it has to be done in the most recent, after the most recent pregnancy. Another requirement is the neutralizing antibody titer has to be at least 1 in 160, but you do not need to do the titer testing at the time of the donation. You can collect the plasma from the patient, and then you can test it at a later date. If the concentration is not high enough, they might use it for other things, but you don't have to wait or waste a donor. And of course, labeling. الناس بتاعين a blood bank, they know this very well, that it's extremely important. Okay, so let's shift gears and talk about D-dimer. It is a degradation product of cross-linked fibrin. There are two types with different cutoffs, and there's 9 different reporting units. فما عشان مثلا جاك الدي دايمر انت اشتغلت في مستشفى الدي دايمر رقم معين الكت اوف بتاعه معناها في المستشفى الثاني حيكون نفس الكت اوف. There might be a different cutoff. So it's very important to become familiar with your with the lab methodology for cutoffs. تمشي ناس المعمل وتقول لهم يا اخوانا داير اعرف الدي دايمر الكت اوف بتاعكم شنو. عشان لما يجيك البيشنت اللي انت شاكي انه عنده COVID-19 او حتى عنده COVID-19 and you're in the middle of the mess, you can't go and ask the lab at that time what's the cutoff, but you have it already. So you know the cutoffs, and you basically can use your clinical judgment at the time right away. It is a highly sensitive test to rule out a venous thromboembolism, but it has low specificity. معناها شنو؟ معناها انه التست لو نيجاتيف يعني low D dimer الحمد لله they're most likely انه ما في DVT ما في PE ما في venous thromboembolism basically. If it is positive يا ساتر جاء من وين؟ Is it venous thromboembolism? Is it DVT or is it something else? There's differential for elevated D dimer. Pregnancy is one. Any inflammation, trauma, malignancy, and the list goes on. So you have to use your clinical judgment. Use pretest probability, of course, and then you test the D dimer, and you look at the patient and you see if you really want to pursue the diagnosis of venous thromboembolism or not. But if it's a negative test, it's most likely not going to be any thromboembolism. There's no consensus on how to use D-dimer levels for management of COVID-19 patients, but the elevated levels might stratify the patient at high risk for poor outcomes or of poor outcomes. عملت جاك البيشنت عنده COVID-19, you did a D-dimer and it's elevated, you start to become worried that this patient might have a poor outcome. So it helps you to stratify who needs more closer monitoring, basically. In the literature, with regards to COVID-19, there was a publication of about 1,099 patients with laboratory confirmed COVID-19 from more than 550 hospitals in China. The D-dimer was higher, or was noted in about 40, elevation was noted about 46% of patients, and it was only about 43% of patients who had elevated D-dimer were non-severe, but compare that to 60% who had more severe disease. So this suggests that maybe higher D-dimer points to more severe illness. There was another cohort in New York City where more patients with an elevated D-dimer were mechanically ventilated than those who were not mechanically ventilated. So again, a suggestion that higher D-dimers might suggest poorer outcomes. All right, so let's talk about thrombosis. It is common in COVID-19, from different case series in critically ill patients. There is less data about non-critically ill patients with regards to incidence of venous thromboembolism in COVID-19. And there's almost no data published about outpatients. So why would this be important? For management purposes, basically. So critically ill patients, there becomes an argument to use therapeutic anticoagulation if there is a concern for venous thromboembolism. They are at a higher risk if they have COVID-19. So you have a lower threshold for using therapeutic anticoagulation in these patients. With regards to ischemic strokes, they were reported, probably not as robust as venous thromboembolisms. There was also reports of microvascular thrombosis in the lungs of some autopsy studies. So there are some theories that this might be the issue, that there's these microvascular thromboses in COVID-19 in patients who develop very severe disease. But you need bigger studies to really confirm that. What about bleeding? Bleeding is less common than clotting in patients who have COVID-19, but it may occur, especially if you're giving therapeutic anticoagulation, the patient is in critical condition. There is a entity they're calling COVID-19 associated coagulopathy. It has a similar picture to DIC, but the risk of bleeding, or the bleeding outcomes were found to be less than DIC. So bleeding can occur also, especially if you're using anticoagulation. So does anticoagulation reduce mortality? According to a study that I'm going to talk about, it does. So the International Society of Thrombosis and Hemostasis proposed a scoring system for sepsis-induced coagulopathy. where they stratified the score to being positive if it's more than 4, or negative if it's less than 4. So they use a platelet count. If it's between 100 to 150, you give a score of 1. If it's less than 100, you give a score of 2. PTINR also, if it's between 1.2 to 1.4, you give a score of 1. If it's higher, you give a score of 2. And then you use the SOFA scores also. If it's more than 2, you give a score of 2. And so you add them up and you get your SIC score. And so the study was based on this SIC score. It was done in Wuhan, China. They randomized 1,786 patients. They excluded patients who had mild and moderate disease, and there had some other exclusion criteria. And so 449 patients were randomized to either receiving heparin or not receiving heparin. And the coagulation parameters here for patients who had severe disease, they tended, patients who had non-severe disease, they tended to have a lower D-dimer compared to those who had severe disease. Notice here it's 4.7 and here it's 1.47 in non-severe disease. And so the differences in PT and platelet count weren't as big. They were statistically significant, but not as clinically significant. But the D-dimer is definitely both clinically and statistically significant. And so from this, the 28-day mortality rate in patients who were treated with heparin was lower, and patients who had severe disease, who had a score of SIC score of more than 4, versus those who were not treated with heparin. So the mortality rate here was 64%, and here it was 40% in the heparin treated arm. And this is statistically significant. Those who had a lower score, an SIC score that was less than 4, it wasn't statistically significant, and the differences weren't very big in terms of the mortality. And so this basically proved that that the mortality improves when you anticoagulate patients with COVID-19, especially if they have a high SIC score and if they had severe disease. So based on that and on other data, the International Society for Thrombosis and Hemostasis came out with interim guidance on recognition and management of coagulopathy and COVID-19. And so in order of decreasing importance, or in decreasing order of importance, you do these tests. So you do a D-dimer, it's probably most important. And you do a PT, a platelet count, and a fibrinogen, probably not less as important, and especially it's not available in all laboratories. And so if the D-dimer is very elevated, the PT is prolonged, the platelet count is low, and if the fibrinogen is low, then these patients might need admission, even if there are no other concerns, because they are at a higher risk of getting thrombosis. And you would start prophylactic anticoagulation. If the D-dimer or all these parameters are worsening, then you might consider doing some experimental therapies to catch them before they succumb to the illness. If they don't have a very elevated D-dimer and PT is normal, platelet count is normal, if there's another cause to give them to admit them, then you give them anticoagulation prophylactically. If they don't need or they don't have any other criteria for admission, you can discharge them safely, and have them just isolate themselves at home. So what VTE or DVT prophylaxis should we use? You use, for all hospitalized patients, You use low molecular weight heparin. If it's not available, you can use unfractionated heparin, or patients who are undergoing dialysis or have a creatinine clearance less than 15, even if they're not on dialysis, you use unfractionated heparin, but low molecular weight heparin is preferred. And there is a theoretical possibility that it has an anti-inflammatory effect. Patients who are in the ICU, there is a debate that they need higher dose of anticoagulation, but like I said, this is still debatable. VTE confirmation is difficult in this time because the resources are stretched. There might be issues with the PPE availability, etc. So not all patients can get ultrasound and CT pulmonary angiogram, although CTPA is the gold standard to diagnose PE, but sometimes you don't have that luxury. So use your clinical judgment. So if the D-dimer is negative, most likely VTE is negative, especially if you have a low Wells score. But if the D-dimer is elevated and you can't confirm it radiologically, you ask yourself, when should I consider empiric therapeutic anticoagulation? Suggestion: use if otherwise there's unexplained respiratory failure that's not due to fluid overload or ARDS or something like that, especially if you have elevated D-dimer, then you might want to give them therapeutic anticoagulation. Or if they have some physical features to suggest thrombosis, then you might want to give them therapeutic anticoagulation. So what about patients who are already taking anticoagulation as outpatient? Let's say a patient has atrial fibrillation or they have a history of DVT, what should you do then? If they are, yes, then you should typically continue anticoagulation unless there is another contraindication. If they are hospitalized, you might want to use a shorter acting anticoagulant. Simply, if you need to stop it at any moment for an urgent procedure that has a higher bleeding risk or something like that, then you can do that more safely rather than using oral agents that might take longer to clear from the body. If they're not using any anticoagulation, then what we said before. What about thrombocytopenia? There are some studies that say that mild thrombocytopenia is common, especially in more severe disease, COVID-19, but severe thrombocytopenia is very rare in COVID-19 infections so far, as far as we know from published data. But it has been associated with worse outcomes when it does occur. And so platelet transfusion should be given only in the setting of bleeding or an invasive procedure with high bleeding risk. فما أي عيان عنده thrombocytopenia وعنده COVID-19 طوال يدوه platelet transfusion. You have to have good indications to do so. So patients who have ITP, immune thrombocytopenic purpura, they can be given thromboprophylaxis if they don't have any evidence of bleeding. Most ITP patients don't bleed unless their platelet count is less than 20,000 or 10,000. And if that happens, you give them IVIG. You don't necessarily have to transfuse them right away. If they start bleeding, then you give them platelet transfusion. But not all ITP patients need platelet transfusion when they get COVID-19. And you do give them thromboprophylaxis or DVT prophylaxis. What about patients who had splenectomy؟ وما بس العيانين اللي عملوه surgery، يعني ما بس العيان اللي عمل حادث وهو صغير وعملوه splenectomy لأنه كان عنده severe bleeding. حتى العيان اللي عنده autosplenectomy، مثلا sickle cell disease patients, they autosplenectomize, they infarct their spleen and they lose the spleen. And so there's no data to suggest that they are at high risk for COVID-19, لكن viral infections أساساً they are complicated by bacterial superinfections. So the management should be the same as those without COVID-19. You give them urgent IV antibiotics and you monitor them very closely because they are at high risk for developing sepsis. Sickle cell disease, speaking of sickle cell disease, they do have underlying cardiopulmonary comorbidity, which may predispose them to poor outcomes if they develop severe COVID-19. نحن السودان بلد أفريقي, a lot of Africans and African Americans, if you are in the States or if you are in UK or a lot of other countries, lots of African patients or Black patients have sickle cell disease. And so you have to be aware of this, that these patients might have a poor outcome if they develop severe COVID-19. There is an entity, acute chest syndrome, that occurs in sickle cell disease, and the symptoms look a lot like COVID-19. يجيك عيان عنده sickle cell disease, عنده قحة عنده ضيق نفس أو عنده شوية حمى, وشكيت والله يا أخي الزول ده يكون عنده كورونا ولا لا. Acute chest syndrome can be very, very serious and can turn ugly very, very quickly. Just like COVID-19, it can turn very, very quickly to being very severe. So what do you do in that case? You test them for coronavirus. If they don't have it, ما تقول خلاص okay ما عندك كورونا خلاص امشي البيت. No, do a chest X-ray. You did the chest X-ray. If you see a new radio density, then this is acute chest syndrome. طوارئ admission, you might need ICU admission كمان. But if you see diffuse ground glass appearance, this might, and obviously a positive PCR test, then this is COVID-19. حتى إذا ما جاك test result right away, ما رجعت لك طوالي, still admit these patients, monitor them very closely لأنه they can turn south very, very quickly. So be very careful. So taking a good history is actually very important. And I hope most sickle cell disease patients do say that I have sickle cell disease when they present to hospitals. All right, I hope you're not too bored yet, but we're going to shift gears and talk about the neurologic sequela of COVID-19. There are numerous neurologic complications documented for SARS-CoV-1, the first SARS that was in 2003, and other coronaviruses. There was a retrospective observational series that was published in JAMA of about 214 patients in China, and they noted that 36% of patients had some form of CNS or nervous system related finding. Patients who with more severe disease tended to be older patients with multiple comorbidities, and this was more associated with cerebrovascular disease. They had more skeletal muscle injury and depressed levels of consciousness than those who had non-severe disease. And so when you compare severe versus non-severe disease, those who had impaired levels of consciousness and those who had acute cerebrovascular accidents and skeletal muscle injury, this tended to occur more, and this was statistically significant. Some laboratory parameters in those who had severe disease that was also statistically significant was a lower platelet count in patients with CNS symptoms, and a elevated BUN in those with CNS symptoms. And so this can give some sort of suggestion, but not very clinically significant, only statistically significant. So there was another case series of about 5 patients who had ARDS. Sorry, not 5 patients, but 84 patients who had, or 58 patients rather, who had ARDS, and they developed due to COVID-19, and this was associated with more so with encephalopathy, prominent agitation and confusion, and cortical spinal signs. And so ARDS was more associated with these severe CNS features. This was their CSF analysis for these patients. So they had some oligoclonal bands, low albumin levels in the CSF. There was also a case report that was published in the journal Radiology in a patient with presumed COVID-19 associated acute hemorrhagic necrotizing encephalopathy. والحاجة دي rare يعني ما بتحصل كتير. لكن they did report it in this middle-aged woman, and she was working for airline, some airline. فعملوا لها CSF analysis لكن it was traumatic. لكن she had altered mental status, so they ended up doing an MRI, and it demonstrated T2 flare hyperintensity within the bilateral medial temporal lobes. This is in these images here, and in this image here as well, in the temporal lobes as well here. And then there was some evidence of hemorrhage by hypointense signal intensity on susceptibility weighted images. So you're saying here very slight evidence of hemorrhage. And there was some rim enhancement post-contrast in these two images. Sorry, in these images here, D and H. So radiologist might be able to do a better job than I did here. But it basically showed the evidence of disease. There was another case report of meningitis encephalitis-like picture. ودي كانت شوية غريبة. البيشنت حسب الكيس ريبورت إنه كان مشى للفاميلي دكتور بتاعه وقال له يا اخي انا عندي كوف وعندي شنو. لسه كان الابيديميك ما كان انتشر، ما انتشر شديد في العالم. لكن البيشنت ادوه عملوا انفلونزا تيست طلع نيجاتيف، قالوا موست لايكلي انها برضه تكون انفلونزا، ادوه الانتي فايرال لكن ما يتحسن. maybe a few days later في زول لقاه واقع في الشارع. So they picked him up, took him to the hospital, and they did nasopharyngeal swab. It was negative, funny enough. عملوا CSF لكن لأنه لسه كانوا شاكين يعني okay, let's maybe do this SARS-CoV-2 testing. And funny enough, they found it to be positive, and they did an MRI, and it showed an evidence of encephalitis. So this shows you that altered mental status can be a presentation of COVID-19. What about Guillain-Barré or Guillain-Barré syndrome? There was a case series of 5 patients from Italy. The authors did state that the Guillain-Barré associated with COVID-19, it should be distinguished from critical illness, neuropathy, and myopathy. لأنه it looks similar. لكن الفرق إنه Guillain-Barré occurs earlier on in the disease course than the critical illness myopathy and critical illness neuropathy. فإذا العيان بدأ يظهر له features بتاعت AIDP or acute inflammatory demyelinating polyradiculopathy, think of that actually, not it's just myopathy. ليه الحاجة دي مهمة؟ Because management, these patients can get IVIG. This is what they did for these patients. They gave them IVIG. It didn't work for all of the patients, but it did help some of the patients. The onset of symptoms was about 5 to 10 days after the disease onset. And this was their presentation, lower limb weakness, paresthesias. Some patients develop ataxia and paresthesias. Some patients even develop generalized flaccid tetraparesis and tetraplegia in 4 of these 5 patients. And this developed over 3 to 4 days. And 3 of these patients needed mechanical ventilation. Okay, so in summary, to summarize everything, keep convalescent plasma in the back of your mind for severe COVID-19 and look out for the studies that are ongoing and their results. If this is something that turns out to be very useful for patients who have COVID-19, then you already know about it and you use it early on. I hope انه المعمل المركزي عندنا والبلود banks to really look into maybe studying it in our patients to see if it works. Anticoagulate almost everyone hospitalized for COVID-19 and especially those who are in the ICU. Cerebrovascular accidents, muscle injury, and altered mental status may be the presenting features for COVID-19. So ما يزول عنده altered mental status معناه عنده stroke أو عنده مثلا cerebral malaria أو حاجة زي دي. Also think of COVID-19 also. Radiculopathy, if it happens early on in the disease course of COVID-19, it might be a Guillain-Barré. Okay, and I think I'm done. I'll be taking some questions. We'll see if there's any questions. Okay, so one question is how long do you use thromboprophylaxis? Depending, if the patient is getting prophylactic thromboprophylaxis, if it's if it's thromboprophylaxis, then just during their hospital stay at home, they might not need thromboprophylaxis. لأنه أساسا هم بيكونوا متحركين, they don't need as much DVT prophylaxis. Again, as long as they're hospitalized, you continue the thromboprophylaxis. يمكن لما تعمل لهم downgrading من ال ICU أو ال ITU, like some British, or in the British system they call it, they might need downgrading of their prophylaxis as well. يعني يمكن لو كان بيدون higher doses, you might want to cut down on the doses also. But to keep in mind that patients, you also have to think of the patient's weight when you are giving prophylaxis. So it's not just one dose for everyone. The weight is very important actually in giving prophylaxis. So heavier patients need higher prophylactic dosings. If you're talking about therapeutic anticoagulation, there hasn't been much information as to the differences of who gets what for how long when it comes to COVID-19. But I would think, I would suggest that you use the usual recommendations for therapeutic anticoagulation. Okay, there's another question about using aspirin for those who are above 60. I didn't see any data to talk about using aspirin for the thromboprophylaxis in COVID-19 hospitalized patients. So I really can't comment on that. They do recommend low molecular weight heparin. But if a patient has, and it seems like these patients can develop some cardiac issues, the COVID-19 patients. So if they are already at high risk for cardiovascular disease, you might want to consider using aspirin for cardiovascular protection. But this is just recommendations for the general population, not necessarily just COVID-19 patients. Okay, another question is, how much amount of plasma for treatment or for giving treatment? To be honest, I don't have much information on how much convalescent plasma is given to patients, but with regards to donors, they say that 2 to 3 patients can benefit from one donation. So it can be quite useful actually. So, encourage patients who have COVID-19 to donate. And especially when antibody tests become more widespread and widely used, then these patients might actually benefit from getting or from donating convalescent plasma. And you can easily pick these patients up, even if they didn't get tested during their illness. Okay, and if there are no further questions, I will conclude my talk. Thank you for listening, and I hope this was educational. Thank you.